Correct. Yeah. I mean, I think the easiest way to go about doing this is just give the hormone that's missing without attention to where the deficiency is. Why this becomes relevant is if you have a 35-year-old guy whose testosterone is low, but you can demonstrate that it's low because he's not getting enough of a signal from the pituitary, why would you bother giving him more testosterone when he has the he has the Leydig cells and the Sertoli cells to make testosterone? He just needs the signal. Sometimes, though not always, just a course of Clomid can wake him up and he's back to making normal testosterone.
So he'll do this 3 times a week, 50 milligrams 3 times a week for a short course. And then,
yeah, we would do that for 8 to 12 weeks and then we reevaluate.
And estrogen and testosterone will increase in parallel.
Yes. And again, it depends. Aromatase activity is dependent on how much body fat you have and genetics. And if estradiol gets too high, we think if it gets over about 55, 60, we will give microdoses of anastrozole. But it has to be real microdoses. I mean, you cannot pound people with anastrozole. To give you perspective, the sort of on-label use, like if you just go to a pharmacy and order anastrozole, you're going to get 1 milligram tablets. Like we can't give anybody a milligram.
They'll feel like garbage.
We have to have it compounded at 0.1 milligrams, and we might give a patient 0.1 2 to 3 times a week. That would be a big dose of anastrozole.
Yeah, I think that the typical TRT clinic out there is giving 200 milligrams per mil, 1 mil, 200 milligrams of testosterone once every 2 weeks, and then hitting people with multiple milligrams of anastrozole, and they're all over the place.
I've never really understood.